Healthcare is vital. Access to healthcare is what we all need when we get sick, but it's not lack of healthcare that leads us to get sick in the first place. It means that people working in healthcare need to be working alongside others who are addressing the social determinants of health. And that should be important right through the life course, whether it's focusing on good early child development, for example, as good pediatricians do. They recognize that the families from which children come are vitally important, or right through the life course at the other end, supporting older people. All societies have health inequalities. If we look at people by income, education, or some other measure of social position, what we find is the lower people are in the social hierarchy, the worse their health. In addition, in a country like Australia, there are huge differences in health between the Indigenous and the non-Indigenous population. These are not primarily due to lack of health care. They're due to the conditions in which people are born, grow, live and work and age, and to inequities in power, money and resources that give rise to the inequity in these conditions of daily life. And that's what we mean by the social determinants of health as causes of health inequities. I've conducted various reviews of the evidence of the causes and what we can do about the causes of health inequities. And for example, in my English review, I had 6 domains of recommendations. First, give every child the best start in life. Second, education and lifelong learning. Third, employment and working conditions. Fourth, everyone should have at least the minimum income necessary for a healthy life. Fifth, healthy and sustainable places in which to live and work. And the 6th is taking what I call a social determinants approach to prevention. We know that smoking, unhealthy diet, lack of exercise and the like are causes of ill health. We need to address the causes of the causes, those factors that are responsible for the fact that these causes follow the social gradient. The lower you are in the hierarchy, the more likely you are to have these unhealthy behaviours.
The Green Square Health One project is really quite different. It's part of an overall state strategy in New South Wales Health for the development of health ones that are specifically designed to meet the needs of their local communities. The Green Square Health One is going to be really different because it's the first one that's built in an urban setting and it's in a very heavily populated community. We've got challenges in terms of physical activity, in transport, and the Health One is working with all of our stakeholders within the university, within the City of Sydney, with urban growth, very importantly with our GPs and allied health to look at how do we create a healthy community that provides integrated care across the whole of the spectrum. More importantly, our Health One will bring together a whole range of different clinical and specialist services like drug and alcohol services, mental health services, building on our early childhood services. From the Health One, we will continue to be providing services within people's homes, but also in the other places where community gather in the community centres. So we are looking at not just providing everything within a building. So we want to do things that are really different. We want to link in with the local cinema and the local shopping centre, and how do we have healthy messages that are within those environments? How can we have cooking classes and nutrition within the local supermarket? How can we work in with the local businesses so that they understand the health needs of their broader communities, so that we're using all of the resources within that community to improve the health and well-being of the community?
So about 4 years ago, we were approached by some communities some Aboriginal communities in the central north of New South Wales, and they wanted us to help them solve what they described as a 30-year problem in oral health. And so there was an existing service, but it was not working for them. It was expensive, it was really poorly designed, and people only went to that service when they had a really bad toothache. So we then partnered with those communities and with government and philanthropy and anyone else who would contribute in a sustainable way to design a new oral health service for those communities that would meet their needs. So we adopted a collective impact model to achieve that, and what that means is understanding the problem from the community's perspective and then working with the community to actually design and implement the solutions. Our collective impact model of oral health care is delivering measurably high quality oral health services across 11 Aboriginal communities, and that we're doing that with local Aboriginal staff in communities and in schools. We recently had a costing study of 2 years of data, and our little community model of care provided 47% more treatment at 25% of the cost of comparable service. And that what that tells us is not only is the service working, but it's highly efficient. And in lots of ways, we shouldn't be surprised by that when communities help us to design and deliver services, of course they work and of course they're more efficient. One of the unexpected benefits of this service is that we've been able to work with communities to create local employment and to enable people to complete their qualifications, and that's really setting people up for the future, and we're pretty excited about that.
The gaps that occur for consumers in the healthcare system are around access to health services and the cost of them and transport. I want to talk a little bit about my own experience with care, in that I have 5 medical conditions that are chronic, and I have a 9-member multidisciplinary team of health professionals who help me look after those conditions, and I don't have a case manager. So therefore, I'm the only person who conveys and communicates what's happening. Doctors do talk to doctors, but podiatrists don't necessarily talk to doctors, and physiotherapists don't talk to doctors. So there's a gap as well as a disadvantage in me not having a case manager. One of the other gaps that happens for people when they want to get care is that they're often referred by their GP to an allied health professional for a series of sessions. It can be 5 sessions or 6 sessions, and for a variety of conditions. But what doesn't get explained to people, and what the consumers don't understand, is that there's a cost involved. And when they think that the sessions are free under Medicare, but when they actually get to the allied health professional, they are covered by Medicare, but there's always a gap that has to be paid to cover the expenses of the allied health professional's fees. So the consumers then find themselves having to pay, say, $30, $40 on top of the Medicare allowance, and they can't afford that. So therefore they go 1 session, pay that, and then drop out. Another gap that we have is that there's not enough ability between allied health professionals and doctors to actually develop shared healthcare plans. The reason why is that there's difficulty with the technology. It's not consistently talking to each other, and so therefore people don't get shared healthcare plans. One of the other issues is that practitioners need time if they're going to have patients at the centre of care. There's been a lot of talk about patients being at the centre of care, but in practice that does not happen because the time you have to allocate to do that as a practitioner is quite an amount, and that isn't covered by either Medicare or quite often by the way you run your practice. So we need more commitment to patients being at the centre of care and the time being allocated to deal with that.